Good afternoon. I'd like to thank the committee for allowing me to present my data today. And the title of my presentation is that Angiopoietin 2 levels are elevated in the third trimester of pregnant women living with HIV on protease inhibitor combined antiretroviral therapy. As you are all aware, pregnant women living with HIV are routinely treated with combined antiretroviral therapies in order to prevent the transmission of HIV from mother to baby. Lopinavir-ritonavir boosted therapy is a protease inhibitor that's been widely used in pregnancy in the past decade. In the developed world, lopinavir is no longer a first-line regimen in pregnancy, but it does remain an alternate therapy if needed. However, in the low-resource setting, it's often the only protease inhibitor that is available. We know that protease inhibitor use in pregnancy is associated with higher rates of adverse birth outcomes, higher numbers of small for gestational babies, and an increased incidence of preterm birth has been reported in numerous studies. We know that starting protease inhibitor ART prior to conception is also associated with greater odds of a small for gestational age birth versus if the therapy is started during the course of pregnancy. And in this schematic from Rebecca Zash's study in the Botswana SEMPO study, you can see that any adverse birth outcomes are increased when lopinavir is the protease inhibitor in the combined antiretroviral therapy. To investigate this, we established a prospective cohort of pregnant women living with and without HIV in Toronto, Canada. We matched for maternal age, race, parity, and BMI, and excluded things that would possibly impinge on results. So, drug use, smoking, hypertension, or vascular or immune disease. We sampled blood across the course of gestational at the point of clinical care, and we collected cord blood and placenta at delivery. The overarching question of this project was, do protease inhibitors affect placenta formation and function? Placental development is a tightly regulated process. It must be complete by 26 weeks of gestation to be able to support fetal growth. In this schematic, if you follow the blue line, which indicates placental weight, you can see that the placenta grows to its maximum at 60% of gestation, and this is equivalent to the end of the second trimester of pregnancy. It must do this in order to be capable of transmitting enough oxygen and nutrients from maternal to the fetal circulation to support the exponential fetal growth in the last trimester. We know that placental development is tightly regulated by a whole family of pro- and anti-angiogenic molecules. Vascular endothelial growth factor and placenta growth factor are two of the key proteins, and they act on their receptors to stimulate endothelial cell proliferation and migration and nitric oxide release, which are all important in vascular development. Endothelial progenitor cells are recruited into the placenta, and the family which I'm going to talk about, the angiopoietin growth factor family, so angiopoietin 1 and 2 and Ty2, play an important role in the branching and looping capillary stage of the last and smaller terminal villi of the placenta. And in the schematic of a placental cotyledon, you can see that the fetoplacental vascular tree is analogous to that of a deciduous tree, and these are the leaves at the ends of the terminal villi where the gastric and nutrient exchange occurs. In order to investigate the developmental effects of these protease inhibitors on placentas and pregnancy, we've also developed a pregnant mouse model in our lab. In this model, the pregnant mice are treated from day one of pregnancy across the course of gestation, and then we take their placentas and fetuses and study them. In this data, you can see in a casting and microcomputer tomography of placentas from control or protease inhibitor treated pregnancies that the placenta shows a pro-angiogenic shift in these smaller vessels. When we quantified this using the analysis tools, we found that there was a doubling in the number of the smallest arterioles, equivalent to these little purple ones in the placenta, and these are 35 to 70 micrometer vessels, and this is as small as the casting can go. When we looked at growth factors in these placentas, we found that VEGF was equally expressed between control and lopinavir treated groups. However, the S-FLT, the soluble receptor for VEGF, was decreased. Consequently, when we looked at the ratio of VEGF to S-FLT, it was pushed towards the VEGF side of the equation, and we hypothesized that this pro-VEGF, pro-angiogenic shift could contribute to that overbranching in the mouse placenta that we observed. And our question became, does this happen in the human placental cohort? When we looked at the placentas from the pregnant women living with HIV on PI cart and compared them to the healthy controls, we did see a change in their terminal villi. In the image on the top, a terminal villus from a healthy placenta shows a thin vasculo-syncytial membrane and large sinusoidal capillaries, and this vasculo-syncytial membrane is very thin and is the only barrier between the maternal and fetal circulations, and this is the point of efficient transfer. In contrast, in the protease inhibitor exposed placenta, the terminal villi had a thickened syncytium and also increased number of very small capillaries, which were tightly packed with fetal red blood cells. When we quantified the number of vessels in each terminal villus, we found a progressive stepwise increase corresponding to severity of the placental compromise. So AGA is an average for gestational age baby, and SGA is a small baby in the women living with HIV on protease inhibitor cart. We have previously shown that progesterone levels are decreased in the maternal serum of these women, and low levels of progesterone correlated directly with the increased number of vessels in these cases. Moving on to our investigations of the angiopoietin growth factors, we found that angiopoietin 1 and Tie2 levels were not affected. They were expressed equally between HIV and HIV negative and positive groups, and they did not change across the course of gestation. In contrast, angiopoietin 2 was expressed at a high level in early gestation and then decreased to term, and this is consistent with its role as an antagonist of angiopoietin 1. So angiopoietin 1 acts to mature vessels, and so the declining expression of angiopoietin 2 will allow angiopoietin 1 to mediate its effect in this looping, coiling, branching of the terminal villus. However, in the particular point of gestation where these terminal villi develop, angiopoietin 2 levels were higher than that of the control group. When we looked at the angiopoietin 2 to angiopoietin 1 ratio, so if this is pushed to the angiopoietin 2 side, this leads to increased vessel instability and branching angiogenesis. We found that that was significantly different at 28 to 32 weeks at the time of terminal villus formation. We then asked if angiopoietin 2 levels would have a predictive capability for poor placentation or be able to separate the groups by HIV status, and we found that between 28 and 36 weeks, with 95% confidence intervals, levels of angiopoietin 2 were significantly raised in the pregnant women living with HIV on PI cart. In summary, protease inhibitor combined antiretroviral therapy in pregnancy is associated with placental pathology and increased branching angiogenesis in the terminal villi. We know that disturbances in the balance of pro and anti-angiogenic factors contribute to placental pathology, and in this study we've shown that angiopoietin 2 levels are increased in the mid-gestation in the plasma of women living with HIV on PI cart, and we suggest that this may be a biomarker of developing placental vascular maladaptation. I would like to say thank you to my colleagues Smriti Kala and Hakmini Mohammadi, who processed all the placentas and plasma for this study, Michael Jamploski and Alexander Schlatter, who've been involved in the analysis of the vascular networks in the mouse and human placentas, and all of our clinical colleagues at St Michael's Hospital, University Health Network, Mount Sinai Hospital, Women's College Hospital. And a very special thanks go to all of the women who have supported this research through their participation. Thank you, and if you have any questions, I'll be happy to answer them.